series is sponsored by Eli Lilly.
Welcome and thank you for dedicating your time to attend this meeting. At Lilly, we are committed to following the letter and the spirit of laws, regulations, policies, and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label approved in our country. Any questions related to unapproved drugs or indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and we wish you a good meeting.
So what I will be doing in this short symposium will try to give some overview how we can improve the care we deliver to our patient with type 2 in a specific stage of the course of type 2 diabetes. That is the early stage, and try to show you how that can contribute to a long-term success in the outcomes of these patients. This is my disclosures for conflict of interest, and this is the indications and limitation of tirzepatide, which will be discussed during this presentation. This is going to be the agenda for the next 25 minutes. I'll start by trying to answer the question, do we really need to worry about this early stage of type 2 diabetes? And then try to show you how we can optimize the care in this stage of the disease, and specifically look into how newer tools like tirzepatide can help us improve the outcomes of this patient working in this stage, and then some summaries toward the end of this presentation. During the course of this presentation, we're going to listen to the story of one of the patients who is in the early stage of type 2, and then I'll make some comments and explanation to how we can do things better. So we'll start with listening to this real patient talking about his experience with the early stage of type 2 diabetes.
Sometimes when the life takes you in one direction, you don't know anything about what's going on unless they tell you. When they tell you, that time you feel bad. I felt very bad. My reaction was like, I was shocked. But to be honest, after a while, I was thinking, why I'm shocked? Lifestyle is bad. Food I'm taking, it's all junk food everywhere. So why I'm shocked? So I have to take care of myself. But for the first, let's say 3 months, I was in a very bad mental condition. I thought that any disease, I know I used to work in a hospital before, so I know that there is disease, you take medications for like 2 weeks, 1 month, 2 months, 1 year, the disease will be gone. I thought the same. They kill you when they say that this is for a lifetime.
So this patient is clearly worried early in his type 2 diabetes journey. But as physicians and healthcare professionals, do we need to worry about this early stage? Do we need to do things differently to improve the outcomes of this patient? What I'll be trying to show you why we have to worry about this early stage and what is the importance of this one. The first piece of evidence that I'll share you that microvascular complications can happen quite early in the course of this disease. And in this analysis, I've looked into the prevalence of microvascular complications in patients newly diagnosed with type 2. In the green columns, those diagnosed in primary care settings, and in orange columns, those diagnosed during screening campaigns. And you can see things like impaired sensation in up to 40% of the patients, and microalbuminuria in those diagnosed in primary care, almost 27% having evidence of microalbuminuria. And it's not only these microvascular complications, but even cardiovascular disease risk is significantly higher early in the course of the disease. So apparently, this underlying mechanism for these complications do start early, even at the time of prediabetes, as we start learning recently. Now, this is a large cohort study from Denmark, where they have looked into more than 140,000 patients newly diagnosed with diabetes, and they compared them into matched group non-diabetic from the general population. And they have found that the 10-year cardiovascular disease risk is significantly higher even at that early stage of type 2 diabetes, 27% compared to those without diabetes. And mortality is 35% cardiovascular mortality in those newly diagnosed with type 2 diabetes. And a very important observation is the impact of the age at the time of onset. Because if you compare the hazard ratio to cardiovascular events in those diagnosed below the age of 40, it is almost double that for those diagnosed later in the course of their life. 2.62 for those below the age of 40, compared to 1.3 hazard ratio in those diagnosed after the age of 40. And unfortunately, we see a lot of patients early diagnosed in this part of the world. And this is again showing you the direct relationship of age at onset to the higher risk of cardiovascular events, which give us additional reason to worry. And this has been supported by a large amount of evidence. In this slide, I quoting age referencing, showing that early onset, that is below the age of 40, compared to those above the age of 40 at the time of the diagnosis, significant risk of complications, significant risk of mortality, and just an example, the risk of MI is 14 times higher to their matched group compared to 4 times in those above the age of 40. And this recent study published in Lancet Diabetes and Endocrinology showing you the direct relationship between age at the time of onset to the mortality, whether it is all-cause mortality to the left or cardiovascular mortality to the right, from a very large analysis, more than 23 million patient year observation. So strong reasons to worry about patients who are young, recently diagnosed with type 2 diabetes. But unfortunately, there is a significant inertia in handling this stage of the disease. And I'll try to show you what are the consequences of this delay in taking this period of the disease seriously. The first one, we've learned that there will be a progressive failure of the beta cells mediated by what we know as glucotoxicity if we don't intervene with our most intensive treatment strategies earlier in the course of the disease. And from longitudinal studies like the UK BDS, we know that will contribute to failure in the future in achieving target. This has been supported by studies like this from the UK Clinical Practice Research Data Link, which compare the outcomes of glucose control if you intervene early. So if you intensify treatment within the first year of failure, when the A1C is above 7, that's what sort of improvement in A1C you can achieve. If you use the same approach, but a bit later, more than 1 year, that's what you would expect, probably secondary to the progression in the pathophysiological defects. It's not only the glucose control, but the efficacy, as you can see, with the same class of agent, the GLP-1s, if we use them early as a first-line treatment, we get significantly better efficacy compared to when we use them later in the course of the disease. And in this study, you can see the direct relationship between how early we use agents and how we can get in terms of glycemic efficacy. Complications also going to increase significantly when we don't intervene early and aggressively. And this has been shown by a number of analyses. This is from, again, the UK Clinical Practice Research Data Link, a large registry, more than 105,000 patients, and a 1-year delay in maintaining glucose control below 7 resulted in more than 60% increase in the risk of cardiovascular events. And you can see the number from the different endpoints. Another study, 34,000 patients, followed for 10 years. And what they were trying to compare, the difference between early excellent control, that maintaining the A1C below 6.5 within the first year of the diagnosis, resulted in 20% risk reduction in MI, almost 20% risk reduction in all-cause mortality. If you delay this by more than 1 year, and then you follow the patient for 10 years, you see some benefit, but it's significantly less. 7% in MI, 3% in mortality, just supporting the idea that if we act early, we can make a difference to the outcomes. Now, Hashem managed to convince you that we have to do things differently in the early course of the disease, how we can do things differently. And again, we're going to listen to Manaf about his experience in the early stage of the disease.
For me, Diabetic is worse than cancer because there's lots of restrictions, lots of things that not to do. Not to do list, it's a big one in your life. So for me, it's like irritating my, everything inside me. So main challenge is monitoring your blood sugar all the time, using blood sugar. But thank God now I have this sensor. The sensor is helped me a lot. I put, you can see it on the phone. You can monitor on the phone every single second. Your blood sugar is high, blood sugar is down. So the challenging is how to manage my blood sugar was till now the most important thing in my life right now, because I want to see my kids growing in front of me, and this is for others. If you want to live a good life, monitor your food. The main fear for me is my eyesight.
I think we all want our patients to live longer, to live healthier. So how we can handle this early stage to enable them to do so. And I will mention two important aspects that we can handle in this early stage. The first one is to use effective treatment strategies, because we've learned that traditional approaches, when we use metformin monotherapy, regardless to the baseline A1C, as per traditional guidances, is not the best way of maintaining excellent glucose control. As you can see in this analysis, if your patient is having an A1C of 8, for example, and you start him on metformin monotherapy, the chance that he will stay controlled by the end of the first year is only 37%, and significantly less the higher the baseline A1C. And you will say, okay, if he's not controlled, I'm going to add another agent. There is significant inertia linked to this old reactive approach to treatment, meaning that there will be accumulation of poor glycemic legacy that will contribute to the risk of complications. So we must be moving to a more proactive approach where we start effective treatment strategy early to ensure that we achieve and maintain glucose control in most of our patients, to ensure that they have the best outcomes in the long term. And this has been supported by a number of evidences, as you're all familiar from the UK PDS and onward. But the verified trial, which is a trial that looked into patients newly diagnosed with diabetes, not on treatment, and A1C below 7, they've been randomized to receive intensive therapy, that is combination, even if the A1C is below 7, compared to monotherapy with metformin. And over the course of 5 years in this study, the combination was metformin DB4, but we see even a change in the pathophysiology, because the beta cell function, measured here by the HOMA-P indices, has significantly improved when you start aggressively, when you start with combination from the beginning compared to the expected decline in the beta cell function when you start traditionally with metformin. So it's clearly that if we start early, effectively, we can achieve better and more durable glucose control and likely improve the risk of complication in the future. But what else contributes? Is it only about this glucose control? And the second concept that I want to draw your attention to, that we must have a comprehensive approach to the target in diabetes, because we know that diabetes is associated with multiple complications that you can see in the right side of this slide. And we know that glycemia is a major determinant for the risk of this complication. Some of the underlying pathophysiological defects that lead to glycemia is shown here. There are many others, more than 8, as we know. But there are other factors that increase the risk of complications. What we call them the associated risk factor, which independently and synergistically increase the risk of complication. And if we are to make a difference, we need to have that comprehensive approach, this multifactorial approach in treatment of these patients. And this has been elegantly summarized in the ADA-ESD consensus in the 2022 latest version, where they say that your targets in order to ensure better outcome of complication, glucose control is number 1, but we also have to optimally treat the associated cardiovascular risk factor. And we have to improve weight management in this patient. And in those who are high or very high risk, we need to use agent with proven cardiorenal protection. And although weight is one of the known cardiovascular risk factors, but it has been separated as a separate target because of its importance, which we can see here, for example. This is a study from this region, more than 111,000 patients. And the conclusion is that BMI above 30 independently increase the risk of complication of diabetes, regardless to glucose control or to other issues. And we learned that if we improve weight, especially if we cause significant weight loss, as you can see in this analysis, if we reach 10, 15%, we can even induce better outcomes on heart failure, on mortality, on diabetes remission, making weight an important target in people with type 2 diabetes. And this will bring me to speak about the new tool that we have available and see to which extent it can help us improve the outcome of patients in this stage of the disease. You're familiar with the tirzepatide molecule, one of the latest tools available for us to treat people with type 2. It's the first dual incretin agonist available to us, so it simultaneously stimulates the GLP-1, the GIP, half-life of 5 days, which enable once weekly administration. You've heard about how does it act. We're all familiar with the traditional action based on the GLP-1 experience that we have, glucose-dependent stimulation of insulin and inhibition of glucagon. But there are also actions on gastric emptying, on appetite, which will contribute to weight loss and indirectly to glucose control. And we'll see a newer action mediated by the GIP, where they will act on the peripheral subcutaneous tissue to improve insulin sensitivity, lipid buffering, which will significantly contribute to the benefit and to the efficacy in terms of glucose control and other outcomes as we see. And if we see how that translates into evidence, and here I'm just quickly summarize to you the studies from the clinical development program of this molecule, the SURPASS studies. And here you can see that tirzepatide in the different grades of the blue color, the 5, the 10, the 15 milligram, compared to either placebo or comparators, including insulin or other GLP-1s, showing very significantly unprecedented glycemic efficacy, where from a baseline of 8 to 8.5, we see a 2.5% decrease in the A1C, which enable more than 90% of the patients, as in the SURPASS-2, to achieve an A1C below 7. Not only this, but we're now talking about a normal level A1C, because 50% of the patients were able to achieve an A1C that is below 5.7, which is something we don't used to know from previous tool that we use. And the other important target, as we said, is weight. And you're all familiar with the efficacy of this class of medications on weight, which enable more than 85% of the patients to achieve clinically meaningful weight loss, more than 5% weight loss. And again, more optimism, we're seeing more than 40% of the patient achieving significant weight loss, a 15% or more weight loss that I've showed you earlier can lead to a significant impact on things like heart failure, on things like mortality, and improvement on all the associated complications of diabetes. Not only this, but we're seeing a trend for positive impact on other metabolic parameters. We've said we need a comprehensive approach to associate risk factors. So clinically relevant decrease in both systolic, diastolic blood pressure, close to 25% decrease in the serum triglyceride that has been observed in the SURPASS-2 study with the use of this molecule. Safety, you're all familiar. We didn't see something new. It is what we've been used to with the GLP-1 based treatment. The transient, mild to moderate upper GI side effects, nothing unusual that is we can see with this class of medications. Now, I'll just quickly show you how does the guideline look into this early stage and the concept that I've tried to discuss with you. And if we look into the 2025 ADA standards of care, I'll mention 3 Class A recommendations from this guideline. The first one, treatment intensification shouldn't be delayed. We have to act early because time matters in diabetes. The second, you have to make sure that your treatment you choose is sufficiently effective to get your patient to the target. talking about use of effective strategies that I've mentioned. And thirdly, this comprehensive approach. Try to select agents that deliver additional benefits, things like weight improvement on top of glycemia only approach that we used to. And this is, you also familiar with this algorithm for treatment. There is a section to the left talking about the cardiorenal protection, which is very important. And there is a section to the left talking about weight and glucose management. And they have specifically classified agents into categories to help you with understanding the importance of efficacy. Because now we have tier 1, tier 2, tier 3 in glycemia, with agents like semaglutide, tirzepatide, combinations, and insulin was on the top. And similarly for weight, we have classification based on efficacy, again with tirzepatide, semaglutide on tier 1 class, to help you to choose how you can get patient to your target. Tirzepatide in Ramadan, you've heard from Professor Hanif, nothing different from GLP-1s. No dose reduction is required. You just have to make sure that titration has been completed well before Ramadan to avoid any unexpected new GI side effect during the course of Ramadan. Now, we will hear to the experience of Manaf, who was started on tirzepatide early in the course of his type 2 diabetes.
Even when I eat now, before and when I eat, they say it in English, I used to pick up like a lot, big portion. Especially, I came from background in Iraq, we eat a lot. We eat very, very fatty food. After that, now I'm eating like 1 scoop of rice, a little bit. I don't want to feel full at all, just only to engage my stomach with some food, and that's it. Shift me in a very good position that I feel very satisfied, psychologically, emotionally, everything. Shifted me from one place to another place when I feel like there is an improvement. When there is an improvement, sometimes, let me tell you something. Sometimes you go to the hospital, you take a blood test, and you have nothing, you feel nothing. Nothing wrong with your body. But when you go there, then you discover that your blood sugar is very high. You black out. You go home, for example, kids, hi dad, how are you? You cannot talk to them. You feel that there is something wrong with you. But when you take a blood test and you go after to take the results and the doctor tell you, Manaf, you controlled your medication, you feel like a winner. You win something. That's how, psychologically it affects person when he's in a good health.
So you've heard the impact of efficacy when it comes to improving the A1C, but that translates into satisfaction, into the sense of winning, into the sense of the need to continue and to contribute to care in patients, what we have seen with Manaf and hopefully with many patients. And that will bring me to the final section of this presentation. We'll try to summarize what I've been saying. The first one, this early stage of type 2 is a crucial period where we have the chance to make a change to the trajectory of this disease. Early intensive control provide a legacy benefit in the long-term outcome. We've got huge amount of evidence to support this. Using effective treatment strategies will ensure that we go to our target rapidly and safely. And this comprehensive approach to the target, where we control weight, control associated risk factor, will enable us to deliver the best long-term outcomes. We're lucky now we have tools to enable us to do so. In this specific workshop, I've tried to discuss tirzepatide, which have substantial glycemic efficacy that ensure that you get into target, together with remarkable unprecedented impact on weight and extended benefit on other metabolic parameters. Blood pressure, we've seen the impact on lipid profile and others, and the convenience of once weekly use in addition to the established safety and tolerability. So just in summary, I think I have 30 seconds to say that we need to act early. We need to use effective treatment strategies and agents that offer an extended benefit on all the important challenges that we face in type 2 in order to bring a real difference to the life of these patients. And by this, I will thank you very much for your time and attention.